This is the case of a 19-year-old male patient that presented with nasal obstruction. He underwent surgery somewhere else, but it was avoided because of significant arterial bleeding. The mass is hypervascular with multiple cysts, compatible with an aneurysmal bone cyst of the sinonasal cavity and skull base region, and you see of very large dimension. The patient was transferred to Stanford from an international location for definitive treatment. You can see the close relationship of the hypervascular mass with the internal carotid arteries and the skull base, the vision of the tumor, especially towards the right side of the paraclinical region, likely affecting the optic canal on that area. The expansion of the clinoid process is very obvious on that right side, and the involvement all the way to the middle canal fossa on each side. So this represents a challenge because of the hypervascularity of this lesion. First, our ENT group is performing the sinonasal stage of the operation, opening into the nasal cavity. We start moving some of the initial cysts, identifying the nasopharynx inferiorly or the nasopharyngeal fascia, all the way down to the Clival bone posteriorly. We see some of the involved bone that is being removed, some of the small cysts, using the Doppler ultrasound, trying to find the carotid artery. And the key here is to have reliable landmarks. That is the dura of the pituitary gland I found first. You can identify how vascularized the dura is because it's giving vascular supply to this tumor. The good thing is that those bleeders can easily slow down with just some gentle pressure. We expose the dura of the prechiasmatic sulcus, remove the tuberculum sella. We're going to be moving towards the optic canal. You see the soft constitutive mass, and as we remove it, again, significant arterial bleeding. These are branches directly from the carotid artery, meningeal branches. You can see the abnormal bone being removed. And again, we coagulate dura at the level of the sella and tuberculum sella. Always being very cautious with the location of the paraclinoidal segment of the carotid artery. We continue exposing the dura of the sella, prechiasmatic sulcus, tuberculum sella, now even planaris finidale anteriorly. That is the area above the optic canal, what we call the supraoptic recess. All that bone is being exposed. We can see now finally the dura of the planaris finidale. And now we're exposing the anterior wall of the cavernous sinus on this side. And this is removing the bone that covers the coronal segment of the carotid artery. We obtain bleeding again from around that area. Feeders directly going to the tumor. That's the opening, the cavernous sinus being partially open. It's important in this case to remove all abnormal bone, and that's why we are being aggressive, removing this area here stuck to the carotid artery in the coronal space. Now we continue with our drilling down to the level of the foramen lacerum, Clival region. The carotid artery has been fully skeletonized. We are uncovering the whole anterior aspect of the cavernous sinus and removing all the Clival bone. Again, we do not want to leave any abnormal bone because the tumor will recur. We are again removing more bone now on the right side towards the anterior wall of the cavernous sinus. Again, causes again here with possible arterial bleeding again. And now we are exposing the orbital apex, optic canal, as you can see here, and you see you get significant arterial bleeding near the orbital apex. We proceed with caution, trying to identify this dural branch that is feeding the tumor, and we identified it's probably a branch of the ethmoidal system. Another one here that we gently coagulate. You see these are rebel branches, but with careful coagulation we can control them. Remove all this abnormal bone around the orbital apex on the right side. And then when we keep removing this abnormal tumor to expose all the way to normal dura, this again, the area on the paraclival and foramen lacerum, again arterial bleeding that we control easily. We can see V2 prominence with another bleeder around V2. This is exposing again the anterior wall of the cavernous sinus and paraclival corridor on the right side. Dura of the middle coronal fossa is also being exposed. And now we drill towards the petrous apex and jugular tubercle on this patient's right side. And this is some tumor left at the clinoidal area on the patient's right side. We see the optic nerve nicely exposed, the dura pulsating on the planum sphenidale, the cavity created by the tumor. This is some of the optic strut that is left. You can see we are working lateral to the clinoidal carotid, and we are emptying this optic strut to make sure there is no residual tumor left. So we finally accomplished a complete tumor resection. This patient has been 3 years since surgery with no recurrence, complete resection, and intact vision. Thank you.